Okay, so we'll go ahead and get started. So, welcome everyone to this installment of the National Fellow Online Lecture Series. I'm Robbie Bowers at Emory in Atlanta, Georgia. I'll serve as the moderator for this talk tonight. So, before we get started, a couple housekeeping issues. The next talk is going to be next Wednesday at 8:30. It'll be on safe sport and sexual trauma. The speaker will be Sherilyn Stefano, and the moderator is going to be Mel Rubish. So tonight's lecture will be on a general review of injections. Our speaker is going to be Dr. Walter Sussman from Boston Sports and Biologics in Boston. And again, I'll serve as the moderator. So again, as we say before all of these lectures, this content is to serve as an adjunct to your individual program's educational content. We want to provide people that are tuning into this and fellows with direct access to educational experiences with a wide variety and diversity of AMSSM members and invited guest speakers sometimes. And really a key goal of these is to assist in CAQ exam preparation. So during the talk tonight, while Dr. Sussman's talking, please mute your device's microphone, turn off your video. You can submit questions through the chat function. After Dr. Sussman finishes his talk, I will then ask those questions in a Q&A session. We'll have 5 or 10 minutes at the end to do that. And then please complete the evaluation at the end of the lecture. So we do want audience input, and really any AMSSM member who has input on specific topics or speakers, you can provide that input to us, and that can be through the AMSSM website. If you then go to the Education tab, click on Fellow Online Lecture Series, and then that will take you to the suggestion page. You can also use this QR code. And again, just remember, as you're making your suggestions, really a primary goal of this lecture series is to assist in CAQ exam preparation. So to get started tonight, again, tonight's lecture is on a general review of injections. I think it's going to provide a lot of applicable content that's evidence-based for new fellows and for residents. Certainly it will help with day-to-day practice as well as exam preparation. The speaker tonight is Dr. Walter Sussman. He did his medical school at University of New England, his PM&R residency at Emory in Atlanta, Georgia, and his fellowship in sports medicine at Emory as well. He was a resident in PM&R program at Emory a few years before me. He's been a great mentor and a great resource to me through my career, and I think that he'll bring a lot of high-level content to the talk tonight. So without further ado, Walter, if you want to take it away.
All right, let me share my screen. You guys see all this?
Yeah, all good.
All right, perfect. So a few disclosures. I do have there's a textbook out there, the Interventional Orthopedic Procedure Atlas. And the way this is broken down is the initial sections are really how do you choose your inject dates? Because part of this is how to get a needle in the right place, but how do we deliver the right medicine to get the best outcome? I'm a board member for the Interventional Orthobiologic Foundation, which also is an educational organization that teaches how to perform a lot of these procedures that these injections could be used in. And I'm also a consultant for a couple of different orthobiologic organizations. We're going to start with corticosteroids. This is probably the most common injectate that most of us are using out there. It's been around since the 1950s, 1949, when it really started to get used in clinical practice. And there are 4 different FDA-approved intra-articular injectates. Some of these are particulate, non-particulate preparations. They vary in dosage, relative anti-inflammatory properties, and their half-life. And this is a great study by Dan Cushman at University of Utah looking at what we actually use. So they did a survey of AMSSM physicians, and most of us are using triamcinolone, followed by methylprednisolone. Most of us are diluting our corticosteroid injections with lidocaine. And the mechanism of action is pretty simple. It's anti-inflammatory and immunosuppressive. And it has the clinical effects of decreasing erythema, swelling, and pain. There's also an interesting mechanism where it increases hyaluronic acid concentration in joints. The indications, it's frequently used for both acute and chronic pain. In my practice, it typically has a big role in acute OA flares. We're trying to really decrease the inflammation and swelling in a joint. There aren't that many side effects associated with it. There can be flares or cortisone reactions, this typically begins within 6 to 12 hours after the injection and typically spontaneously resolves with ice and NSAIDs within a couple of days. The typical onset, if you're trying to prepare a patient, is 3 to 7 days. So often we'll tell patients they typically will feel pretty good from the anesthetic for a few hours. And then once that wears off, they may feel no improvement until the end of the week. And when hopefully they're starting to notice some clinical improvement in their symptoms. There's good evidence that intra-articular corticosteroids can be effective, but the benefit over placebo tends to be relatively short-lived. Depending on the study, it tends to outperform placebos between 4 and 6 weeks. So there are a number of different statements from international and American organizations, and none of these organizations are very high in corticosteroids, although they're not very high on most of the injections we use, either hyaluronic acid or PRP. And most of them note that it does have a short-term effect, but it doesn't seem to have long-term benefit. So as far as whether or not this is effective, this is a good systematic review looking at over 500 studies. And again, intra-articular corticosteroid injections tend to outperform everything in the short term, less than 6 weeks. But there doesn't seem to be a benefit over any controls, either hyaluronic acid, NSAIDs, or physical therapy in the medium term. And most of the controls outperform corticosteroid injections once you get to 24 weeks. Now, the other question we have to ask when we consider using corticosteroids is, are they safe? Each year I have more patients requesting that we don't use corticosteroid injections, that we try something else. And that's because some of these articles that have gotten a lot of press over the past couple of years. And so the McAllendon article from Boston Medical Center, they looked at patients over a 2-year span where they compared corticosteroid injections versus saline every 3 months. And they looked at cartilage volume loss, and compared to the saline control, the corticosteroid injection group lost twice as much cartilage. Now, it's important to note that in the average knee, there's about 3 millimeters of cartilage, and you're only losing 0.2 millimeters of cartilage compared to 0.1. So this may or may not be clinically significant, but it's twice as much as the control. And then Zhang et al. In a follow-up study in 2019 looked at 4-year data, matching corticosteroids to another cohort of comparators, and they showed that the corticosteroid group showed rapid worsening of the arthritis on plain films compared to the control groups. As far as safety in tendons, people have looked at this as well, more in animal studies than human studies. This is a rat study from about 25 years ago, looking at 3 or 5 corticosteroid injections versus saline around the rotator cuff. And once you get to 5 injections, you do start to see histologic changes in the tendons with signs of necrosis and disorganization of the collagen bundles. This may be dose dependent, 3 versus 5 injections. This is another study looking at different doses of triamcinolone around a tendon. And with the higher doses, with the 1 milligram doses, you start to see irreversible damage and to cell morphology and viability when compared to lower doses, where you did see a recovery after the corticosteroid injections, the lower dose corticosteroid injections over a 3-month period or 3-week period. This is another interesting study. This is a retrospective study, again, looking at the number of injections. In this case, it was for lateral epicondylitis. And as you start to see increasing numbers of injections, you start to see calcifications around the tendon. And so about 6 injections, you start to see these calcifications within the tendon. So again, this was also related to the number of injections. So potentially a negative adverse events associated with higher number of injections, higher doses of corticosteroids. And so the question I always ask is this worth it? And study after study that have come out over the past 10, 15 years really show that these corticosteroid injections can provide some benefit in the short term, 6 weeks, 3 months, somewhere in that window, and then the efficacy seems to wear off. And so what are the alternative injections? Toradol is increasingly getting used in our clinics, and more interest because of some of these studies showing the negative side effects of corticosteroid injections. So Toradol is approved for moderate to severe acute onset pain. It's available in multiple different doses, different forms, and it's an NSAID. And so the mechanism of action is similar to any of the other NSAIDs, where it seems to impact the COX cascade and can affect pain, fever, and inflammation. It tends to have more potency than other NSAIDs. And in orthopedics, we're using it in our clinic, and in the literature that we're going to discuss for intra-articular or intrabursal injections. And it seems to be safe, efficacious, and cost-effective. The studies are really limited to subacromial bursitis, rotator cuff tendinopathy, and then osteoarthritis. And when you look at it for subacromial bursitis, the 4 studies that are available at this time, in the short term, it seems to have a similar efficacy for pain and for function when compared to various different types and doses of corticosteroids. It's been studied for adhesive capsulitis as well. One study looking at Toradol compared to hyaluronic acid, and another one comparing it to corticosteroid. And again, it seems to have a similar benefit. In the corticosteroid study, the Toradol seemed to improve range of motion better than the corticosteroids, but otherwise no difference up to 6 months out. For osteoarthritis, again, Toradol seems to be a viable alternative to corticosteroid, with no difference between the Toradol groups and the corticosteroid groups. And again, this is varying doses from 40 to 80 milligrams of triamcinolone with similar outcomes. Contraindications. So it has a similar side effect profile to other NSAIDs. So you have to worry about GI considerations, renal considerations, impacts on blood pressure. There are considerations that we have to take into account with pregnancy and with breastfeeding as well. Hyaluronic acid, this is another workhorse in our clinic. This is FDA approved for the treatment of osteoarthritis, specifically knee osteoarthritis, in patients that have failed to respond to other conservative treatments, including non-pharmacologic therapy and simple analgesics. What's interesting about hyaluronic acid is it's actually FDA approved as a device to alter the viscosity of the joint and not as a drug. And the indications are really pain in patients with mild to moderate arthritis who have not responded to other medications. But it hasn't been FDA approved for other joints at this time, although there are studies looking at this or at other joints. There are different preparations, so there are different brands that are available. This is a list of some of them. They vary in their molecular weight. So there's high molecular, moderate, and low molecular weight preparations, and that's based on the kilodalton of the molecules within the hyaluronic acid. They vary in viscosity, dosage, i.e. the number of injections that are required. Some of those are a single injection. Some of them you have to administer over a series of 3 to 5 injections, typically spaced about a week apart. Some of these are avian origin, made from rooster combs, but there are also bacterial biofermentation preparations. And it seems like, based on existing literature and what has come out so far, that the higher molecular weight preparations may have some advantages over the smaller or lower molecular weight preparations. The mechanisms of action, we don't really understand this very well. There's a couple different mechanisms that have been proposed, but in general, when you have a degenerative joint, you see the concentration of the size of the individual hyaluronic acid molecules within the joint decrease, and this affects the viscosity of the synovial fluid. And the thought process is that the hyaluronic acid may stimulate the native synovial cells to produce a more viscous hyaluronic acid in the joint. It also seems to have some anti-inflammatory and anti-nociceptive effects. The half-life for these medications is usually between 1 and 9 days, although Duralene, which is one of the preparations, seems to have a half-life closer to 30 days. And so if these are cleared within a week on average or less, the mechanism has to be something where we're altering the intrinsic status of the joint, hence the thought that maybe the synovial cells are being brought back online to produce that thicker joint fluid. There's a Cochrane review from 2006, so nothing that's been updated since then. This looked at 76 studies of intra-articular hyaluronic acid that demonstrated improved pain and function in about 28 to 54% of patients, and this varied depending on the product that was used. There are subsequent meta-analyses and systematic reviews that do support the long-term superiority of hyaluronic acid over corticosteroid injections with benefits up to 6 months. There were studies looking at patients over 65 showing that hyaluronic acid injection was able to delay a total knee arthroplasty by 8 months, which isn't a lot, but there are subsequent studies like this one where you treat a patient with over 5 hyaluronic acid injections every 6 months apart in successfully helping patients delay a total knee arthroplasty for over 3 years. And so repeating these is typically how we use them clinically. Most insurances will pay for these every 6 months and a day. We'll talk about insurance coverage in a minute. It doesn't seem to be a disease modifying drug. So when compared to hyaluronic acid, at least in this study, the progression of arthritis radiographically was similar. And when we look at radiographic progression, we're usually looking at this Kellgren-Lawrence grading scale. This is important, like we talked about reimbursement. These medications usually have to be prior authorized. So unlike corticosteroid or Toradol, which is a fairly cheap medication, these can be a couple $100 per injection, closer to $1,000 an injection. So most insurance companies require that this be authorized. Most of them will require you to grade the severity of arthritis using the Kellgren-Lawrence staging. So, this is a slide to be aware of. If you're trying to prepare a note that's going to be accepted by the insurance company to get authorized, including the grade and including what medications that they've tried is often helpful to getting that approved. Medicare doesn't require prior authorization, but most commercial insurances do. As far as a couple of procedural considerations, these are injected into the joint. When they're extra articularly placed, usually in the Hoffa fat pad or in the suprapatellar recess, usually these are fairly painful. And so if a patient's having a lot of pain as you're doing a knee injection, it's a good sign that you're probably not in the right place. Reassess where your needle is, double check the ultrasound or redirect it because you're likely putting it in the fat pad. If there's an effusion, you could try to aspirate the effusion beforehand, and that can confirm that you're in the joint. And in fact, if there is an effusion, you should aspirate the joint before any of these injections. You don't necessarily have to inject lidocaine. That's optional with the hyaluronic acid injections, just like it is with any of these injections, but it tends to be a little more comfortable. And typically, similar to Toradol and corticosteroid injections, we're telling patients to rest or avoid higher impact or strenuous activity for 48 to 72 hours after the injection. As far as adverse effects or reactions to hyaluronic acid, you can see reactions at the site of the injection. 2% of patients will experience a post-injection flare with more pain and swelling and redness or warmth. You can have the pseudoseptic reaction. This typically responds to ice and rest, but these typically will aspirate, will send the fluid for analysis just to make sure that there isn't a true infection. You can see hypersensitivity reactions with these too. So you want to make sure that none of your patients have an egg or chicken allergy because of the similarity in the molecule, even with the biofermented products. And then you could have more generalized effects, just like with any medication. So rash, arthralgia, myalgia, muscle cramps, and nausea have all been reported with these injections as well, but not commonly. As far as contraindications, anybody who has a hypersensitivity to hyaluronic acid or previous injections, you may want to steer them away from these injections. Severe allergic reactions or anaphylaxis to hyaluronic acid or eggs, is another kind of contraindication. Again, there are some pregnancy or breastfeeding considerations as the safety hasn't been established for these injections. PRP, this is another common injection that we're seeing more and more clinically. There's a lot of information on the slide, so I'm going to try to kind of walk through this because the FDA definition of PRP is a little fuzzy. The FDA defines PRP as an autologous blood product with a higher concentration of platelets above baseline. We'll talk about dosing of PRP in a little bit, but it's a broad definition. So we often get the question from patients and from colleagues, is this regulated by the FDA? And the FDA doesn't really regulate the practice of medicine. It regulates drugs and devices. And they've stated that PRP is a product derived from patient's own blood. So they don't consider it a drug. But there are also FDA documents declaring that any procedure which uses human cells has the potential to be regulated and subject to clinical oversight when it's more than minimally manipulated. And in that case, they would treat it as a drug because it's no longer a blood product. It's something else that you've kind of manipulated beyond those specific cell lines. So there are regulations around PRP, and most of them are around the systems that we're using to make PRP. And so there's a 510 FDA clearance pathway. And so all the PRP systems that are used commercially have gone through this FDA clearance process. And clearance doesn't mean that it's approved for a specific indication. And most of these are considered off-label, and that's because the initial clearance for a PRP system was for the intention of mixing the PRP with bone graft material to enhance healing properties in orthopedic procedures. And so if you're not mixing the PRP with bone graft and applying it that way, it's considered off-label. And that's the stance, and bottom line is it's considered an off-label use of these products. Now, the other thing to consider, especially when you guys get out into clinical practice, is that there's another regulating body that we think about when we start talking about orthobiologics, and that's the Federal Trade Commission, because they market advertising and marketing. And so you can't market a procedure or a drug for an off-label indication. And so these really haven't been approved for any orthopedic conditions such as osteoarthritis, tendonitis, any of these things that we're using it commonly in clinical practice for. It's really only approved to mix with bone graft. So if you're going to have something on your website, or in e-brochures, that's the only thing that you can claim that PRP is used to treat for. Now, if you're in a room counseling a patient, that's different. You can go over the studies, you can go over the data, because the Federal Trade Commission isn't coming into your exam room and looking at what you're discussing with the patient. That's not part of their purview. And so there's a big component of the ethical practice of orthobiologics, especially since most of these things aren't covered by insurance. And this is a great study that Shane Shapiro's group did out of the Mayo Clinic, and they have a consult surface to educate patients about orthobiologic procedures. And what they found is that 75% or over 75% of patients that ended up at our clinic asking about these injections have never had a conversation with a medical professional. They were getting information from friends or from online searches. And so our number one role with this and with any of these injections is to educate our patients. And even before that, we got to figure out what the firm diagnosis is. And then we can start talking about what injectate we're going to be using and coming up with a treatment plan, and really making this a shared decision that both you and your patient are comfortable with. And we should tier our recommendations based on the evidence. There's certain things that we have really good evidence that this works and this works for this long. And there's certain things that haven't really been studied and there's not literature on. And so when we talk about the different PRP preparations, we're talking about taking whole blood, where platelets comprise about 6% of your blood, to a product that has 94% concentration of platelets. And there are different systems to do this. So there's over 50 commercial systems to do this, and they make PRP differently. So not every PRP preparation is the same. And even with the same system, you can change your protocols to make a different output. So it's not like Toradol, where you can pull it off the shelf and you know exactly your dose based on milligrams. And there are multiple factors that play a role. So the input, what's coming out of the patient, platelet counts vary in a patient throughout the day, depending on if they've exercised, depending on their diet. And they vary between patients, and the quality of the platelets will change over time. And as we age, our platelets tend to lose some of their regenerative capacity or ability to stimulate regenerative capacity in cells. The PRP can vary in how much blood you can input into the system, what the platelet capture rate is of that system, what your final volume of PRP is, and other cell lines. And so not all PRP is the same. And we can see it with this study. This is an analysis of different commercial systems. And the 4 graphs at the bottom show variations in platelets and white blood cells and neutrophils and lymphocytes across these systems. And there's big differences in actually the cell counts within these that are produced in the PRP products out of these different systems. There have been different attempts to try to classify or characterize PRP. The PLRA classification is a system that was published by Mountainer et al. Rob and one of our mentors. But there are other classification systems out there. The Rossi article is a great summary of the history of these different classification systems, but there's no real accepted standard in place. Again, different protocols will yield different products, and it makes it really challenging to compare head-to-head the different studies that are out there. So historically, you'll hear, is that PRP leukocyte-rich or leukocyte-poor? What are you using? Well, even that definition is very vague because there's no definition. Those definitions don't account for what concentration of leukocytes, what lineages of leukocytes are included in those preparations. And so even these don't have a clear classification or clear definition of what is a leukocyte-rich and leukocyte-poor preparation. And so the trend has been moving towards talking about PRP similar to other injectates, is what's the dose? And so historically, we've talked about, is this, what's the concentration compared to baseline? So is it 5x baseline? Is it 7x baseline? But the problem is, like we talked about before, the baseline can vary because platelets can vary among patients or even within the same patient, depending on when you draw their blood. And so hard numbers, what's the actual platelet number in that preparation is kind of the trend. So we can say there's 5 billion platelets that we delivered into this joint, or 10 billion. And that is going to allow us to compare the studies across the board a little bit better. So mechanism of action, we're going to talk about tendon and osteoarthritis because this is the most common indications in my clinic and probably yours, but it is being used in surgery, in axial injections for non-unions and interosseous injections, and there's some data for ligaments as well. And so the mechanism of action, at least for tendinopathy, is pretty straightforward. We're taking a chronic tendon injury, we're inducing an acute injury to it, or tricking the body into thinking that by injecting a concentrated dose of platelets. And then with rehab and time, we're hoping that it goes through the healing process in the right way. And so the thought is that some of these degenerative tendons are stuck in this proliferative phase, this degenerative phase, and the PRP is going to snap it out of that by, again, creating an acute injury, creating that inflammation stage from ground zero, and then hopefully going through a proliferative and remodeling or maturation phases. So PRP is just a dose of cytokines and growth factors that are hopefully starting and promoting that healing cascade.
And so the idea of doing this with the tenotomy isn't new.
Oh, sorry, the audio is coming over, but there is studies looking at tenotomies, and the concept is pretty similar. You're inducing a traumatic injury to the tendon and following these patients for a period of time, and we've been doing this since the 80s and with good results. And so PRP in basic science studies is that it does seem to be able to induce proliferation of tenocytes, and there seems to be a dose relationship. Again, going back to the concept of dosing with PRP, and so a 10% concentration of PRP. So you take a 50 cc blood draw, you concentrate that down to 5 cc's of PRP. That seems to have the most proliferative response with tenocytes. When you start going up to 20%, you actually see a decrease in the proliferation rate. So it probably is a dose relationship based on the basic science literature. And when we start looking at clinical literature, and this is a great review by Everett et al., and what they did is they took all the published studies that are out there for soft tissue injuries across the board, and they looked at the dose of PRP. They only included studies that had a control group, and it seems to be around 3.5 billion where you start to see consistently positive studies. And so when you look at that chart at the bottom, the blue bubbles are positive studies and the black bubbles are negative studies. And so studies under 3 billion platelet dose seem to be negative, and above 3.5 billion, you start to see more positive studies. Again, suggesting that there probably is a dose relationship to these. And so if we think about this like any of the medications we're talking about today, 1.5 billion platelets doesn't seem to be very effective, but at 3.5 billion or higher, so these high dose or very high dose platelets, we start to see some positive effects with tendons. Now, other question I get a lot is, we had one PRP injection, it didn't help. What do I do now? Do I go on to surgery? Well, not necessarily. There are studies looking at if you do a second PRP injection, and this is across the board from Achilles to patella to patella to perineal, lateral medial condylitis. A second injection does seem to induce further healing, not only symptom improvement and patient satisfaction, but actually healing on follow-up ultrasound imaging. As far as osteoarthritis, again, there are basic science studies showing that there is proliferation of chondrocytes in vitro. There was also a dose relationship. What's interesting is you need a 20% PRP concentration to see the maximum proliferation. So a higher dose in osteoarthritis potentially. But there's some inconsistencies between what we're seeing in vitro, on a petri dish, and what we're seeing clinically. And it's probably because the process is just more complicated in clinical practice. And so are they effective for the joints? This is a very, very well done study. It was published in JAMA, and they used 3 weekly intra-articular injections comparing PRP to saline. It was a relatively low dose PRP injection, so 1.6 billion platelets. And they didn't find any difference between saline and PRP. So it didn't really support the use of PRP for osteoarthritis. But again, this is a very low dose. And when we compare it to some of these higher dose systems, which we'll talk about in a second, the outcomes vary. And so the authors acknowledged that this study shows that a low dose PRP system isn't very, very effective for knee osteoarthritis, and that maybe different doses may be. And so there are studies that have looked at higher doses and do these start to fall in that curve upward on the dose efficacy charts. And so Bansal et al. Looked at a very high dose platelet, 10 billion, so almost 10 times or just under 10 times the dose from the Banal study. And they did find that there was improved function. And what's interesting about the study is that it seemed to protect the articular cartilage from further wear compared to hyaluronic acid. So there seemed to be a disease modifying effect. And you remember the slide where we talked about hyaluronic acid compared to corticosteroid injections, and there wasn't really a big difference. Here we do see that maybe there is a difference. This is another study looking at a higher dose system. So they did 3 injections of 4 billion platelets, which did seem to show, again, greater symptom relief, and again, slowing of the progression of the arthritis when compared to saline control. And a third study looking at superdose, so over 5 billion platelets, a single injection seemed to outperform the lower dose, the $2.8 billion platelet, 8 billion platelet dose. And this is a study by Berrigan, kind of summarizing a lot of the studies that are out there, the systematic review comparing PRP to at least one control study. And they found that dose of 5.5 billion seemed to be the tipping point in terms of negative and positive studies. And so PRP can be complicated because there's just so much data out there, and we're still learning what the ideal preparation is. But what's interesting is the past couple of years, we are starting to see this dose response curve starting to fill in. Now there's less studies and less data on mesenchymal stem cells. So this is the other with the biologic injection that we're seeing a lot more frequently in orthopedics. And stem cells, by definition, are a cell population with the ability to self-replicate. And there are a number of different sources that exist. And we typically classify these based on their tissue of origin. Most commonly, we're seeing bone marrow and adipose tissue being used in orthopedics. There's a lot of animal evidence and data out there, and we're just starting to see more clinical studies with humans, human subjects. But this, again, still is in its infancy. We're not going to talk about any of the embryonic or perinatal stem cells. The FDA has been fairly clear that they considered unregulated drugs. There are no FDA indications for any of the umbilical or perinatal products. And if there's not an FDA indication, you can't use it off label. And so as far as the FDA and what we're seeing in the US, we shouldn't be using these products. There are some studies out there. So this is a study from a few years ago a review of 8 trials, just under 300 patients, various tendons, lateral epicondyle, rotator cuff Achilles, patellar tendon. And they found that there is level 3 and 4 evidence that mesenchymal stem cells seem to be superior to controls. But there's no high level evidence yet. I included this study because it's a really interesting one because it's one of the few ones comparing PRP to bone marrow stem cells. Again, this is for patellar tendinopathy, looking at a proximal lesion over 3 millimeters. And they showed that both groups had significant improvement in pain and function. But when you followed these with MRI, bone marrow actually showed restoration of the tendon structure at that 6-month follow-up MRI. And so there does seem to be some difference in how these cell-based products stimulate healing or not. As far as osteoarthritis, there's a couple studies. This is one that Rob was involved with, looking at IMFAT and bone marrow for knee arthritis. And about 50 patients in each group with over a year follow-up. And both groups showed significant improvement in pain, improvement in function, but no difference between the micronized fat or the bone marrow stem cells. This is a very large, multi-center, well-designed randomized control study looking at bone marrow, adipose stem cells, umbilical stem cells, and corticosteroid injections. And at a year, there was really no difference between any of these groups or changes in imaging on follow-up MRIs. But I think they're going to have a follow-up study with longer-term data, hopefully coming out this year. So that's a ton of information, and you know, the goal in our clinic, and hopefully what you guys are going to start seeing is, there's a huge treatment gap between what we've historically done to treat chronic tendons and osteoarthritis. Weight loss, physical therapy, steroids, NSAIDs can be effective for a lot of patients, but not all. And then it seems like there's a big treatment gap between that and surgery. And so there's a lot of stuff, and we just talked about a couple of the injectates, but there's tenotomy, there's radiofrequency ablation, there's nerve hydrodissection trigger points, tendon scraping, Botox for orthopedics, shockwave, all these ultrasound releases, prolotherapy. So there's a lot of stuff that should be filling this gap. And we just touched on some of these injectates, but there's more out there that you have to think about as you're counseling a patient. And the last thing we're going to talk about is the role of imaging, because we can know all our injectates, but we have to get it there somehow. And this is a slide from Chris Centeno, who kind of coined this term interventional orthopedics. And the concept is, we can see a lot of these structures. So that means that we can guide a needle into it, either under fluoroscopic guidance or ultrasound guidance. And if we can get a needle in there, we can start interacting with that tissue and doing it in a less invasive way. I always laugh when people talk about how good landmark guide injections are. And I include this slide in almost every talk I give. This is a slide out, a study out of the Mayo Clinic. And what they did is they had different physicians at levels of training, residents and fellows and attendings, palpate a biceps tendon and put a TUI needle over it. And then they confirmed where that tendon was in relation to the needle. And only 5% of the time was this needle accurately placed over the tendon. And on average, it was about 1.5 centimeters away from where that tendon actually was. And so if we can't palpate these structures accurately, how are we going to inject them accurately? And when you look at the clinical data, this is a study looking at landmark guide versus biceps tendon injections. 87% of the time, you're accurately placing the injectate with ultrasound, whereas only 27% of the time you're accurately placing with landmark guidance. It's a little bit better than the Mayo study, but not great. And this impacts outcomes too. And so this is a recent systematic review and meta-analysis just came out looking at improvements in pain, function, and patient satisfaction with ultrasound-guided injections. And surprise, surprise, the ultrasound-guided injections outperformed landmark-guided injections. There are different opportunities to learn these skills. You're going to learn a ton this year in fellowship, but there are also courses that you can take outside of fellowship, or as you become attendings. IOF has a course in Scottsdale in February, and in the lead up to the course, they have a bunch of different labs. They're cadaveric labs, and we're starting to play with this needle trainer. And what's great about this is you can actually position your patient how you would in clinic instead of a pro section. And this is my 5-year-old learning some techniques with it, and you can't tell the difference like between this and a real needle on imaging. So it's a great way to target a lot of different areas and get comfortable with these injections without actually poking your fellow fellows or struggling on a patient, as your first time. That's all I got for you guys. I know you probably have a lot of questions, and this is my email. So if we don't get to it tonight, feel free to reach out. And I appreciate the attention. I know it's a lot of information.
Cool. Thanks, Walter. Appreciate it. Like I said, a lot of information on different injectates and the rationale for using each of them. So for those that are still here, if you have any questions, please put them in the chat. We have a couple that are in here now. So I'll ask you the first one, and I can kind of chime in too. So the first one is, how long do you tell patients to wait to get a flu or COVID vaccine after corticosteroid injection? So
I know there's some data early on with the COVID vaccine that, I did a lit search when COVID vaccine came out, and it was about 2 weeks where you typically tell patients to avoid the flu shot either before or after the corticosteroid injection, because it seems to decrease the efficacy of the shot. I don't know Rob, you may know if there's more updated studies looking at the COVID vaccine, but in general, that flu vaccine is kind of what I reference when we give patients some guidance.
Right. Yeah. Usually, to be honest with you, I haven't looked into it recently. It's not a question I get nearly as much as I used to get, a couple of years ago. And a couple of years ago, we used to tell them, 1 to 2 weeks between, but I haven't looked into it. All right. So number 2, have you seen much benefit with Toradol injections compared to corticosteroid injections? And I can weigh in on this too.
Yeah. I don't, despite what the literature shows, clinically, I don't think Toradol works as well. I use it a lot with our diabetic patients. We do a lot of high volume hydrodilatations of frozen shoulders, and I'll use corticosteroid as part of that procedure because it seems to increase the efficacy by about 10%. There's that one or two studies we referenced earlier showing that Toradol seems to be as efficacious as corticosteroid, but I don't seem to see the same benefits. And maybe I need to increase my dose. I don't know. Some of those studies used a higher dose of Toradol, 60 milligrams. But that's my clinical experience.
Yeah, for a joint, I actually tend to use a higher dose. So I'll use 60 milligrams in a joint. Give me 1 second here. Sorry, something is. Let's see here. Sorry about that. So, like I said, I'll use a higher dose for a joint. I used to be hot and heavy Toradol for around tendons, just because corticosteroids are so toxic to tendons. But I actually had a handful of patients, enough to where I didn't think it was a coincidence, where Toradol acutely made their symptoms much worse for one reason or the other. So I've kind of backed off using it around tendons. I'll still will in certain situations, but I use it a lot more for joints still. And I find that efficacy is similar between corticosteroid and Toradol. Where I feel like clinically it's different is the duration of action. I feel like corticosteroid does last a little bit longer, but as far as quick effects, I think Toradol is just as helpful. And then also just for younger patients. So I think injecting a joint with cortisone, is deleterious for the cartilage in a younger patient. And we don't see, if you look at the basic science literature, nearly as much effect on cartilage and chondrotoxicity with Toradol. So in a younger patient, I'm much more likely to use Toradol in a joint than corticosteroid.
Yeah, the other way I use it is I'll alternate that with corticosteroids. So patients aren't getting a really long period of relief, and they're trying to delay a procedure. They have a vacation coming up. They just had a recent corticosteroid injection. We'll talk about doing a second injection or trying a different anti-inflammatory.
Right. Um, I'll also say I'll plug. We should hear in the next couple months. There should be a point counterpoint coming out in the PM&R journal between myself and Bill Berrigan wrote the argument for Thordal for an intra-articular injection for knee osteoarthritis, and the other group wrote the counterpoint for corticosteroid. So that should be coming out in the literature, and then it'll go back and forth between the data supporting each. So that'll be helpful for those of you interested in that topic. All right. So next question: do you ever combine PRP with HA for knee OA, and why?
Yeah, there's not a ton of data out there on the combination of the two, or timing. If you're going to combine them, do you do them together? Do you space it out? My practice is usually we'll do an HA injection, and then a month later, we'll do a PRP, or we'll do a series of 3, and the last one we'll do a PRP at the same time as the HA injection. I think there are a few studies out there. There's a study out of Singapore that's going to be coming out looking at combining these two in a syringe. I know the Mayo Clinic has a study looking at combining some of these in a single injectate. And the combination does seem to be more effective than the PRP, at least the pre-published data I've seen. So that's kind of the thought process with it. It may have an added expense, especially if it's a commercial insurance that doesn't cover HA. So those are other factors that aren't necessarily clinical factors, but certainly go into the mix, as we're counseling a patient.
Yeah, my approach is, yes, there is some data that supports it, not certainly high level data. Clinically, I've actually found that it's worked very well in combination by doing it at the same time. And I'll do it, I'll just float it to patients and basically tell them, like, if your insurance will cover it and it's a low copay, then might as well do it at the same time. I don't think it's going to hurt anything. And then certainly for Medicare patients where you can just pull it off the shelf and use it, I think it's worthwhile. So I'll do it in situations where I can, and it's not a significant extra expense to the patient. But if it is going to be a significant extra expense, I don't think it's worth pushing, in my opinion. Okay, so next one is the PRP question. Are you, for a patient with a meniscus tear, are you injecting PRP directly into the meniscus? And if so, kind of have you seen positive results?
Yeah, so we do. The indications really are degenerative meniscus tear. So, younger patients, radial tears, especially if they're having mechanical symptoms, usually we'll refer those out for arthroscopy. But there can be good results. Our protocol is we'll draw 120 cc's of blood, half of it will spin down, and we'll inject that into the joint, trying to get over that 5 billion platelet dose. The second 60 cc's of blood will concentrate that down to 1 or 2. So you're just trying to get 5 billion, 7 billion platelet dose into 1 cc, and we're injecting that into the meniscus. We're putting patients in an unloader brace for 2 weeks, 24/7, and then weaning them out of the brace over a 2-month period. And I've seen pretty good results. It doesn't work in everybody. I have some MRI follow-up showing healing of the meniscus, and then there's some data out there. In general, when you look at the literature, there's some inconsistencies. Some people are just injecting intra-articular, some people are injecting in the meniscus. The intrameniscal injections, the outcomes seem to be somewhere in that 60-70% range as far as efficacy.
Yeah, there's the one study I'm looking back. I wanted to find it. It's an RCT from 2019. The author is Kaminsky, so Kaminski, and they had. Let me see if I can find the results. And they basically said that our trial indicates that percutaneous meniscal trephination augmented with PRP results in significant improvement in the rate of chronic meniscal tear healing. And this procedure decreases in necessity for arthroscopy in the future. So I think this study in RCT that shows a trephination of the meniscus where you pass the needle through the meniscus in the area of tear along with PRP injection is is helpful. So that paper can be a resource if some are interested in that.
And ultrasound diagnosis of meniscal tears isn't bad. I mean, if you look at the data for that, sensitivity, specificity, somewhere in that 80% range. And so you can see these tears. And if you can see the tear, you can guide the needle into it. There's also some studies, a couple studies looking at IMFAD and BMAC. I think they're like one-off studies, but the success rate somewhere in that mid 70 range in terms of outcomes with those.
Right. Okay. And here's a little bit of a loaded question. You didn't touch on it, but I know we use it on our practices. So where does prolotherapy fit into your treatment algorithms?
So I like Prolo for smaller joints. I like Prolo for in-season athletes where you don't really want a significant inflammatory response. We don't really limit athletes past 48, 72 hours after a Prolo injection. Smaller ligaments in the foot and hand without significant disruption can do really well with prolotherapy. We don't really understand the mechanism of Prolo for intra-articular pathology. If at higher doses, it does have a very low pH, and there's neovessels in the knee. My guess is that it probably ablates the neovessels, although people will argue that point. But if that's the case, it may be better for more advanced arthritis, maybe more of a palliative instead of a regenerative effect. So I think with tendons and ligaments, there probably is some regenerative capacity. I think for OA, it's probably not a regenerative mechanism, but it's hard when you don't know the mechanism, figure out where this totally fits in your practice. But it can be very effective. Small rotator cuff tears or tendinopathy, sometimes 1 or 2 prolotherapy injections take care of that, and you avoid the need for PRP injection, which has an added expense and a longer recovery.
Yeah. So, I use prolotherapy a lot around nerves. So a lot of my nerve hydrodissections, I use a lower concentration prolotherapy. There actually was the Anesthesia Society came out with new recommendations as far as injections around nerves. And for a lot of the injections, especially, the highest or the one that we do the most, carpal tunnel injections, they recommended not using corticosteroid. And there are randomized controlled trials out there looking at dextrose prolotherapy, saline, and corticosteroid injections for carpal tunnel injections, and median nerve hydrodissection. The prolotherapy group came out as doing best. So a lot of my nerve hydrodissections, I use prolotherapy for.
Yeah, and so you can get 5% dextrose saline, bags, and you pull off those, and it's really cheap. The problem with Prolo is it's not covered by insurance. So even when you're doing a hydrodissection around a nerve, if you're using the 5% dextrose NeuroProlo, it's something that's going to be an out-of-pocket expense for patients versus if you're doing a normal saline injection. So those are again, these factors, in terms of cost, what's the least expensive, least invasive. And it's definitely in between, the stuff that's covered by insurance and the higher dollar orthobiologic procedures. So it definitely has a role. And I think about it as kind of PRP light, in cases where I think PRP may be overkill, cases where shockwave, we're deciding between shockwave and prolotherapy sometimes in a lot of cases.
Right. And if I'm not going to put it out there in a public forum, but if anyone wants to reach out to me individually to ask how I get around patients having to pay out of pocket for prolotherapy, you can reach out to me, and I'll let you know what I do in order to limit out of pocket expense for patients with prolotherapy. All right, and I think the last question that we have in the chat are, what are your feelings about combining HA with corticosteroid?
So there's studies. I don't know if I've seen a study with HA and steroids, but there's one with Toradol and HA. Right. And patients are happier when you do a Toradol and a HA injection at the same time. And the reason is the HA usually takes 4 to 6 weeks for patients to kind of start noticing clinical benefit, and the Toradol works right away. And so by the time the Toradol is starting to wear off at that 6-week mark, or corticosteroid for that matter, you're starting to see the benefits of the HA. And so I combine them not infrequently, especially when a patient's in a fair amount of pain when we're doing the first HA injection.
Right. So I do the exact same thing. So there are 2 studies that are out there. There's one with hyaluronic acid and knee osteoarthritis, and one hyaluronic acid with first CMC arthritis. Certainly getting the combo of HA and Toradol into a first CMC joint can be painful just from the volume. But outcomes are better with the combination versus HA alone. And it's exactly what Walter was saying. The HA takes 4 to 6 weeks to kick in. The Toradol is going to give you some improvements in pain and inflammation in the first few weeks to give them some improvement on the front end. And so especially if you have a patient that's really flared up and they have an effusion and you have to aspirate, putting some Toradol in with HA is supported by the literature and will make patients happier as well by giving them some improvement on the front end. So I actually combine Toradol with almost all of my HA at this point, as long as there aren't any contraindications to Toradol in these patients, in order to help them. Unless they're just doing the HA for preventative maintenance and they don't really have acute pain, then I'll hold off and I won't do it. And the reason for doing Toradol, again, there's some studies that support it, and then also the chondrotoxic effects of Toradol or Ketorolac versus corticosteroid. Corticosteroid is just much more chondrotoxic, so it makes more sense from a joint health standpoint to do Toradol as opposed to corticosteroid. All right, so that was the last question. I mean, we're getting right up. It's 9:28, so we're right at an hour at 9:30. And so I'll cut it off here. This lecture will be uploaded to the AMSSM YouTube page starting tomorrow. So if anyone wants to go back and rewatch it, I want to thank Dr. Walter Sussman for giving the lecture tonight. And thanks everyone for tuning in.